Hi, everyone. Thanks for joining today's webinar. This is the fourth of a 5-webinar series focusing on 3D imaging. Today's webinar focuses on how 3D imaging can help treat your patients with sleep issues. My name is Adam, Content Marketing Specialist with Schein, and I'll be your moderator. If at any point during the presentation you have questions, please type them into the Q&A section of your control panel, and we will try to cover as many as possible at the end. Please make sure that your volume is up and any large computer applications are closed to ensure a smooth connection. This webinar is sponsored by Schein Dental and Dentsply Sirona. No CE credit is being offered for viewing the on-demand version of this webinar. Our speaker today is Dr. Erin Elliott. Dr. Elliott has lectured extensively on dental sleep medicine and is an active member of the American Academy of Sleep Medicine and American Academy of Dental Sleep Medicine. We are very much looking forward to your presentation, Dr. Elliott. Over to you.
Thanks, Adam, and hello to everyone out there. I am wearing the same outfit as my picture, and that is because I'm actually back at work. I am a practicing general dentist in Post Falls, Idaho, which is way up in the northern panhandle of Idaho between Spokane, Washington, and Missoula, Montana. And I've been in practice since 2003 when I graduated Creighton Dental School. And you can see here that not only am I the dentist at Post Falls Family Dental, but also Sleep Better Northwest. And so I've been treating sleep in my practice since 2009. And that was way back in, the beginning when a lot of patients had never even heard of that connection between dentistry and sleep. It's also way back in the day that medical insurance didn't know about dentistry and sleep. And it's also where a lot of physicians didn't either. And so the environment is good. I know airway is a hot topic right now. I always thought it was, but I had kind of the cards stacked against me. And I will tell you, a lot of people tell me, well, it doesn't work in a dental practice and sleep is hard to implement and medical insurance doesn't pay. But I am here still standing to tell you that it in fact does work. And I know that our audience is there's probably a lot of orthodontists. My focus today is going to be just a broad paintbrush stroke of adult sleep apnea and how we treat with appliances. And I really don't go into depth on side effects either, because I know the dreaded bite change is probably some of your concerns. However, even though we try to mitigate it and try to prevent them, oxygen always trumps bite. How it would be nice if we could preserve the bite as well as treat the airway. And so again, we're not going to talk a lot about surgical options and maxillary expansion. You guys are the expert at that. But I would like to focus on creating awareness in your patients, how to identify it, some of the health consequences, and then just a brief overview of how we could utilize technology in our practice. So here's my team. It is a very large team, but just as in any practice, you guys probably know what I'm talking about, but the staff photo always seems to be the kiss of death. And that is why I have a staff photo that we can individually remove people as needed. So here's the most up-to-date one. So far, most people have survived Corona and they come back to work. It's just that we had 4 pregnant ones and 2 of them are on maternity leave. So it's been a struggle. Saying that, this is an article that I wrote for Dental Sleep Practice, which is a magazine totally dedicated to dental sleep medicine. And what this article is about is essentially how I'm a very nice person, yet when my sales rep came in, the equipment sales rep came in to try to sell me on cone beam, I chased him out of the office. And he was trying to sell me on sleep apnea. And I had been practicing for a long time, treating sleep apnea without cone beam. And so I was like, these sales tactics aren't going to work on me. The patient is upright and awake. And how can you correlate between someone who's horizontal and asleep? Well, come to find out that in a general dental practice, cone beam and in orthodontics, cone beam can be used for so much more. And now that I have invested in it, I've invested in that technology, I can definitely utilize it for sleep, and it has increased case acceptance. There's still not a ton of studies showing that narrow airway automatically means sleep apnea. It is not diagnostic, and it's barely even screening, but how it is a conversation piece. And I utilize it to find dental pathology, but also look at nasal obstructions, turbinates, all of those things that I can help predict the treatment to patients and set expectations. And of course, they say, well, if you invest in this, you will get your return on investment. And again, I was like, oh, there's another sales tactic. But they were right. And so that comes from a practicing general dentist, that we have been able to keep a lot more procedures in-house. And you as orthodontists too can find so much pathology that patients are so thankful and see that you've invested in them. So here I am taking a cone beam. However, I probably could do it. This was definitely for the picture because my team, of course, runs that. I've been able to integrate things into my practice now that I couldn't before, and I have the confidence to do things like place immediate implants, and we do endo and so many more things that we don't refer out. So if you guys are interested in getting the notes today, join Sleep 101. If you go there and input your email, I will send you a link to a Dropbox. And in that Dropbox will be my notes, plus some blow-ups of some of the things that I will show you today, some of the graphics. So when I do teach a 2-day course with Tarun Agrawal, if you've ever heard of him, it's under the 3D Dentist guys. But again, when I teach, it's a lot more on workflow and not necessarily focused on digital. But saying that there is a flow in your practice that kind of must be adhered to. So often dentists jump to the treatment, but that's dentistry. That's kind of the easier part. But first, we have to find this in our patients, create an awareness and an ownership in them, which sometimes is the trickiest part because there's so much denial out there. Get them diagnosed, because we should not be making any appliances without first understanding what that patient has and what level their sleep apnea might be. And then one of the most common hurdles is that medical insurance. Again, I'm here to tell you that medical insurance does in fact cover appliances, and there is a way to get paid as long as you have the proper documentation. But the hope is that if you bring them through this awareness and ownership and diagnosis, and they see what's going on with them, that they don't care what it costs, that they see the value in what you're providing. And I always think about that, because we can sell ortho cases, we can sell implants, but when it comes to something that could possibly save their life and definitely improve the quality of their life, all of a sudden there's like this big wall where medical insurance better take care of it. So I always try to present enough value that we're not just providing a piece of plastic and an appliance, but that we're opening their airway and giving them something more. And then finally, we'll cover some of the treatment. But just to get a better understanding of what sleep apnea is and what we're even dealing with, is the fact that when we're asleep, we obviously want to see an open airway and oxygen to our vital organ, the brain. Actually, the brain is a vital organ, but I actually have been stuck with my teenage boys for the last month, so I'm not quite sure if they are fully using that. And this is obstructive sleep apnea. There is another kind called central, but what we deal with it's the most common when we're identifying anatomical factors, dental signs and symptoms of obstructive sleep apnea. That's what we're talking about, because it is a physical obstruction of the airway. And the patient is making an effort to breathe. It's just that they can't breathe because they have no airflow because they don't have an open airway. And it's usually the tongue and soft palate. I love this view because basically it shows that how large the tongue and the soft palate really is. You know, most people see that just this part of the tongue. And we, of course, as practitioners in the oral cavity, know how large a tongue can be. So if you're working on a crown prep at number 15 and you're afraid of cutting the tongue, they probably have a problem. And who better to identify this than the people that stare at airways all day long? So you can see that if there's an obstruction and the patient is making an effort to breathe, what a bad cycle this can become. So as you go to sleep and your airway narrows, not every sleep apneic snores, however, that usually is a big motivator for them. But what snoring is vibration of soft tissue. It's showing a narrowing of the airway. So as that airway narrows, that airway can collapse, narrow so much that it collapses. That is an apnea, which literally means without air. So the oxygen goes down, the patient's oxygen desaturates, and our CO2 levels go up. And then our brain says, we need oxygen. I'm going to shake you awake, essentially. I'm going to squirt out a little adrenaline, which is cortisol, and that's the stress hormone. And we're kind of already stressed out enough so that we can stimulate that muscle action, stimulate that fight or flight, that survival mode, so that breathing can resume, we relax, we go to sleep, and it happens all over again. It's really important that we go through our sleep stages, that we get into our deep sleep, that we get into REM sleep. That's where the magic happens. That's where our body recovers. It's memory and mood, learning, biological refreshment, neurons repair. So you can see if that's constantly getting interrupted, even though we might be getting the quantity of sleep, we might not be getting the quality of sleep because of this. So again, we're prevented, we're kind of kept in that light stage. And that is not healthy for us. So snoring again shows turbulence or vibration of soft tissue. Then there's something called a hypopnea. Hypo in Latin, I was a Latin nerd in college. Hypo means less than. So hypopnea, not hypoxia, hypopnea essentially means less air. And so what it's showing is a kink in the airway, a kink in the hose, as you could say. And so if there's not enough air getting through and that oxygen desaturates, then that is counted in a sleep test as a hypopnea. So it kind of looks like this in a sleep study. And this is what a sleep study basically measures. Here's brain waves. And then here is airflow measured through a nasal cannula and usually a little extension to account for mouth breathing. And here's effort. So remember I said obstructive sleep apnea is where the patient is making an effort to breathe, but the airway is physically blocked. So in a hypopnea, there's still a squeak of air getting through, still a trickle, but just not enough that the oxygen desaturates and the brain says, start breathing again. And you get these rescue breaths. That's a hypopnea, and it must be 10 seconds or more. Then there's an apnea, and that in Latin means without air or without breath. It is a complete obstruction of the airway. Zero air moving through for 10 seconds or more. And I have seen some pretty crazy things where people on average stop breathing for 30 seconds at a time, 40 seconds at a time, all night long. Like, this is a very devastating and prevalent disease, but it's just not getting talked about. So in an obstructive sleep apnea, again, we can see the brain waves here. We see zero airflow and we see effort. So in this case, in an apnea, there is a complete blockage of the airway for 10 seconds. The oxygen desaturates 3 or 4%, and then the brain says, let's start breathing. And it creates an arousal, which is basically an increase in that brainwave activity, but also bringing your body from a deeper stage of sleep to a lighter stage of sleep. Now, I say the oxygen has to desaturate 3 or 4%. And so that's how sleep studies are measured. It's just that in order to qualify as an apnea or hypopnea for Medicare, that oxygen has to desaturate 4% versus 3 like the rest of the world. So you have to be sicker in order to qualify. So here's an analogy I use with patients and when I teach, is that snoring, again, is showing turbulence. A hypopnea is a little trickle of air, and then an apnea is a complete closure. So in a sleep study, they basically count up how many times there's an apnea and a hypopnea divided by the number of hours slept. And that gives us this scale down here. Now, they say anything under 5 is considered normal, but I want to point out if a patient is symptomatic, this AHI scale was not meant to be the Bible for sleep apnea. In fact, the physician that came up with it kind of regrets that it was taken to by the medical world as well as insurance, because there's something called upper airway resistance syndrome. And it's very common, especially in kind of younger petite women. It can be men too, but it's essentially showing that their airway is constricted, but their body kicks in to keep their airway open. It's fighting and struggling to keep their airway open at the cost of good sleep. And so technically their airway is not collapsing. So they're exhausted. That sympathetic nervous system is on high alert all night long. But since their airway is not collapsing, it doesn't qualify. These are still people that we help. These are still people that I treat. However, it's just that medical insurance won't cover it. And if they go the traditional medical route, oftentimes they're told, oh, you're fine, you're normal, which is a terrible term. So if they're symptomatic, I just keep searching is the point of that. So an AHI of 5 to 14.9 is considered mild, 15 to 30 is moderate, and anything over 30 is severe. Now, there's so much more to a patient than just this number. And so I try not to treat the number as much as the patient. But according to medical insurance eyes, in mild to moderate cases, oral appliance can be used as first-line therapy, which means they don't have to try CPAP first. Anything over 30 is considered severe, and they usually have to show a CPAP intolerance or have a contraindication. And in mild cases, you have to have additionally a comorbidity to get medical insurance to cover it. However, there's a comorbidity of excessive daytime sleepiness that tends to be enough for insurance. The other thing that I look at and we measure is ODI, which is essentially oxygen desaturation index. And it's based on the same scale as you saw previously, same as AHI. And then there's something called nadir, which again is Latin, which means lowest point. So what this measures is what was the minimum that the oxygen went down to? 83, 84, 85. It's pretty crazy what we see. But what's most important is how much time was spent under 90%. And this is something I like to discuss with patients because, we use also the analogy that, if you're in surgery or sedation, because we do sedation in our office, and the oxygen even gets near 90, alarm bells go off and we get nervous and we shake you to start breathing again. So you can imagine that's what your body is doing. However, you're asleep, so you're not aware. And so your body is in this high alert alarm mode for however long at night. So I focus in on how much time was spent under 90 versus just the minimum. And here's why we should care. And it's because it's a common problem. So they, on average, they say it's about 20%. I think it's probably higher if you look at symptomatic people, including even that upper airway resistance syndrome. But they say it's 1 in 4 men and 1 in 10 women, and 50% of the age over the age of 50. And that is because as we get older, we do tend to gain weight, but we do lose muscle tone, and the soft palate does continue to grow. In addition, the incidence becomes equal in men and women at menopausal age. And that is because progesterone and estrogen help keep our airway open. And at menopause, of course, those levels of hormones diminish. And so our airway is much more prone to collapse. In saying that, and when women hit menopause is where a lot of insomnia symptoms show up. And what Mayo Clinic did a study that found with chronic insomnia patients, when they did a sleep test, what they discovered is that 91% of them had moderate to severe sleep apnea. So the insomnia symptoms, they're woken up by that apnea, and then the mind starts racing and they can't get back to sleep. And so it was kind of incorrectly identified as to what the cause is. And if a menopausal woman goes to her doctor and says, I have insomnia issues, then the doctor most likely will prescribe a sleeping pill and not necessarily look at the why. And that is why so many remain undiagnosed, up to 80 to 90%. And sleep apnea is more prevalent than diabetes or asthma. It's just that we're not talking about it. It's much easier. And honestly, physicians don't have time. I don't want to discredit our medical colleagues, but it's just not on their radar. And it's much easier to give blood pressure medication than the sleep study that might discover why they're having high blood pressure issues. Just a graphic to show how common it is. And of the patients that were tired enough to get tested, tired enough to admit they had a problem, right? And tired enough to go get the one and only treatment given to them, how many are actually using it? How many people that were told to get a CPAP or people that refused to get a CPAP are actually using it? And so there's a lot of CPAP intolerant patients that have already gone through the system that just aren't doing anything. And that's where we can come into play. It's about 60% is what I'd say. So how do we identify these patients? That was kind of a background in sleep apnea and what we're looking at and what we're measuring. And this is how we can help discover it in our patients. So there are a lot of health consequences of untreated sleep apnea. And this is one of the things I'll have in that Dropbox folder is kind of a blow up of this. It is not mine. It is totally stolen. So you could probably find it on the Google as well. But you can imagine that if your body's starved of oxygen, that fight or flight is activated when our body is supposed to be resting. You can imagine how much stress there is on the body. So stroke there's a higher incidence of stroke, 3 times more likely. The stress on the heart. We talk about hypertension. Do you have any patients with hypertension? Coronary artery disease, and AFib is very common. And it's not sleep apnea that's causing the AFib. Essentially, it's the AFib incidences that increase with untreated sleep apnea. With treatment, the number of AFib incidences, I don't know a better word, actually goes down below even controls. Then just a congestive heart failure, the sudden death, that men are 30 times higher risk of dying between the ages of 46 and 60, and medical costs 2 times more they use 2 times the healthcare dollars because people with untreated sleep apnea are just kind of sicker and have more medical issues. And then there's just that's not to count the effect it has on your mood. And you could imagine, going back to if you had a newborn baby, what sleep deprivation does to you, or college, right? So the depression and anxiety that goes along with that fight or flight kind of being activated, moodiness, and then just that loss of intimacy, even if you sleep in separate rooms. 25% of married couples sleep in separate bedrooms, and just kind of a general fogginess. And then, of course, the loud snoring is annoying. The divorce rate is higher in snoring couples. Diabetes type 2, deep sleep is where our blood sugars are regulated. And also the cortisol does have an effect, and loss of oxygen has an effect on insulin resistance. And then an increase in weight. Now, oftentimes, unfortunately, sleep apnea is thought of as an old fat man's disease. And it's still thought of that way in the medical world. And so I've sent a lot of patients that I know have sleep apnea, but they're told, oh, no, there's no way you have that. And that's just based on their physical appearance and lack of extra weight. But what I think what weight gain allows is the severity to be worse. I think it starts out as an anatomical issue, crowded airway space, large tongue, small arches, constricted arches. And so when you have untreated sleep apnea, you're tired. Deep sleep is where leptin and ghrelin are regulated. Ghrelin tells us when we're hungry, and leptin tells us when we're full. Cortisol leads to visceral fat increase. And untreated sleep apneics scientifically crave higher carbohydrate foods because our body needs a quicker source of energy. And so all of these things combine to increase the weight and make the sleep apnea worse. So it's one of those chicken or the egg things. In addition, acid reflux, and we can see erosion in the teeth. We can see some of these effects. So as a person is trying to breathe, I mean, if you just Google sleep apnea, you'll get a ton of videos of people getting videotaped in their apneic events. But as they're trying to breathe, it messes with the interthoracic cavity pressures. And it's almost like a vacuum effect to pull acid out of the stomach. ED, my patients don't really talk to me about that. However, it must be a common problem. Otherwise, it wouldn't be every other commercial on the NFL. And then finally, nocturia. This is it's one of, I don't want to say my most favorite things to talk about, but in a consult, we do ask the patient how often they get up and if they use the restroom. Nocturia is a fancy way of saying frequent urination at night. And what most people don't do is they connect the dots between acid reflux and nocturia. To them, it's a bad prostate. It's getting older. It's being so healthy and drinking too much water. So it's not associated with sleep apnea. However, in a lot of these studies, most awakenings and awakenings to use the restroom is actually preceded by apneic events. And on the sleep study, it's so much fun to tell that patient that story, and that the light bulb goes off and their eyes get wide, like, oh, that's why I wake up so much, because you can see it. And that's one of my favorite parts is kind of the detective work that it is for the patient, and treating the patient, not the study. What matters to that patient in your chair right now? So even if we were to just look at these things, not all of them, but these are some of the most common conditions that our patients will come in with. So we can check out, we can screen even before they walk in the door. And we have changed our health history. I don't use a screening questionnaire, really. To me, it's about identifying these things and starting a conversation, and not a piece of paper. But every office is different. Every demographic is different. I'm used to some pretty stubborn patients in a lot of denial. And thickness of the neck. So do we have any patients that follow any of this? Now, dental signs and symptoms, just for overview, I created this checklist of sorts, and this would be in the Dropbox as well. Now, the patient, of course, does not have to check all of these boxes, but here's a general idea of the things that I look for. And I could almost tell you in an airport and identify this in patients walking by. And some of the big ones I think are like a turkey waddle, which shows a retrognathic chin, but also improper placement of the hyoid bone. The hyoid bone is that free-floating horseshoe-shaped bone that the tongue muscles and throat muscles are attached to. Of course, orthodontists know about constricted arches and vaulted palates, and how the tongue, proper placement of the tongue, allows that growth and expansion. And so, if a child had a constricted airway due to tonsils and adenoids and just breathe through their mouth as a kid, oftentimes that translates into a vaulted palate as an adult in a lot of constriction. There is not, the jury's still out on if premolar extraction automatically makes you more prone to sleep apnea. So I have this written here kind of loosely. It's not every premolar extraction case becomes a sleep apneic. However, it's just something to keep in mind that we don't want to constrict the arches. We don't want to constrict the tongue, because the tongue is going to stay inside of those teeth. If we just were to focus, though, on these things, we would see this in a lot of our patients and not even get overwhelmed by all of these other things. But bruxing, I'm going to show you in a moment how that's related. Not every bruxing event is sleep apnea. However, it's enough for us to ask the question of, why are you bruxing? Acid erosion, we already discussed that. And then scallop tongue. What a scallop tongue is basically when a patient opens, there's a few things I look at. So before I lay the patient back, I just have them open. The first thing I'm looking at is to see if their tongue retracts back into the airway. So that's a big sign for me too. The second is how much of that oral cavity is the tongue picking up. Remember that patient that their tongue gets in the way for number 15. I'm looking to see where on the occlusal plane is that tongue related. Is it above it, and does it take up most of the oral cavity? Then the last thing I look at is the scalloping of the tongue. What that tells me is not a decorative term, but it's these little ripples in the side of the tongue. That tells me that there's just not enough room, and so it takes on the indentations of the teeth. Now, if the patient sticks their tongue out, oftentimes the scalloping goes away. So that's why I said just catch it as soon as they open. Lastly, the doctor may look at their airway if they have a problem. Of course, they're going to look past the teeth into the back of the airway and see if there's any infection. Well, what we should start noticing is how narrow is that airway? Is the tissue beat up and swollen? Is it red? These are the sorts of things we look at. And these are the sorts of things that we as dental professionals, hygienists, team members, stare at all day long. So this is where the conversation comes up. We ask our patient, has anyone ever told you you snore? Because if you ask, do you snore? The answer is always no. And I was one of those patients until my husband videotaped me snoring. So I actually am an appliance wearer. But how we can use cone beam, because when I used to tell patients, hey, how do you sleep? They look at me like I was crazy. I asked, do you wake up refreshed in the morning? Have you been told you snore? Start the conversation. They could not comprehend why I cared. And remember, this was 10 years ago. It's not as common nowadays. I think, one, I'm known for this, so the patients aren't surprised. And then second, it is more common knowledge that dentists should be involved with sleep apnea. So the way that we use that cone beam, and if you're questioning whether to get a bigger field of view or not, get the bigger field of view. You'll never regret that. What this shows is the airway. Now, this is even without the volumizer. We have that technology where we can volumize the airway. But even if you were to just show them this connects the dot for patients of, oh, yeah. Oh, I guess I do. Yeah, maybe I'm not getting as good a sleep. Are you a light sleeper is another question I asked. Do you toss and turn? Yeah, maybe, I just thought that was normal because that's how I always slept. So it helps the patient to understand and maybe own a problem or really start to look at themselves a little bit closer. So again, the patient is upright and awake. It's not diagnostic. However, it is a great way to start the conversation. And again, with the CCAT addition, the CCAT Air, I can volumize that airway, and we can see the volume, and we can show patients that. So again, it connects the dots for patients so that they are more willing to move forward in treatment, which the next step would be a sleep study. So how do we get that diagnosis? Remember, I said, can't use the cone beam for that. We need to do what's called a sleep study. And that can be overnight in lab, that's a PSG, or it could be at home. And home sleep tests or HSTs are becoming more and more commonplace. And this is the type of sleep study I own. It's called a Metabite Junior. And we use that diagnostically. We don't diagnose it, but we make it available for patients. And then we get a sleep physician on the cloud to diagnose it. And then we also do refer out. So we kind of have a combination in our workflow. This is what it looks like in that overnight in-lab study. And you can see how intrusive it is. However, it is commonly used it is very accurate. We can get sleep stages because there's leads to the brain. You can see everything. And it is important for really severe patients, sick patients, and people that might have other sleep disorders to do it this way. And a lot of patients tell me, oh, I didn't sleep at all, but it was really enough for us to see that your airway was compromised when you were sleeping, even if it didn't feel like you were having a typical night's sleep. So the home sleep test has an advantage of cost savings, and patients like it better too. There is some resistance to patients getting a sleep study because it's such a hassle or because they have to go spend the night somewhere. So HST removes that barrier for patients. Again, dentists cannot diagnose. And this, I know I'm going to get a lot of questions on this. again, if you go to that Join Sleep 101, I'll provide the Dropbox link, but also you'll be getting an email from me. So you can certainly ask questions if I'm unable to get to them. But in the traditional world, medical pathway, when we identify sleep symptoms in a hygiene patient, we would refer out to the sleep MD, and they'd get in like 2 months, and then they'd get the sleep test, whether it's in the lab or at home, and then they'd have to wait for the results. And then pretty much every patient, no matter what, was getting told to get a CPAP, and then they'd have to go get their CPAP and try that and then turn it back in, and then you just pray that the patient eventually comes back to you. There is more awareness in the sleep physician world for appliances. They still really, really like CPAP. And the reason why is because they know CPAP works. CPAP just blows enough air to blast open the airway with wind. It doesn't give the body oxygen. It's just blasting soft tissue out of the way. And they know it works because it's just going to keep blowing until it works. The problem is it only works if you wear it. And so it's very common for CPAP to be prescribed. And it's because they're unsure with appliances if there's efficacy. And I'm going to show you how we can kind of get around that and how we can give confidence to the physicians that an oral appliance would work for a patient. So again, we have always a sleep physician is involved with the reading of the test and the diagnosis of obstructive sleep apnea, because that's all that medical insurance will cover for is obstructive sleep apnea for an appliance. Now, don't get overwhelmed. Everything is scary at first. Do you remember class 1 occlusal amalgam was scary when we first started in dental school, and now it's super simple? Maybe not for the orthodontist though, but just don't let your team rebel. Don't give up. It is possible. This is an example of a claim. This is from Blue Cross of North Carolina, I think. But essentially you bill out the exam, the cone beam, and the appliance, and they pay. And so you can utilize medical benefits for cone beam. Now, every state is different, every policy is different, but it's just part of our routine to bill it out to medical. Now, am I like breaking the bank on this? No, but I'm helping utilize medical benefits so that we can keep more dental benefits for dentistry. And insurance does cover it. We know which ones do, so otherwise we just kind of charge out a pano. And I hope we don't get a ton of questions on the reimbursement because it's just so different from state to state. I can just give you kind of a general rule that you just have to get started, utilize a third-party biller, get started, start to get familiar with the policies in your area. But it is possible to get paid. And then finally, treatment. So how do we treat this? Of course, we have to be more than just appliances. Lifestyle modifications, so weight loss, quit smoking, no alcohol before bed. Alcohol doesn't help us sleep better. It just sedates us so that we don't wake up when our airway collapses. It does relax muscle, so your snoring, your sleep apnea can get worse with alcohol. Positional therapy. Oftentimes some patients are severe on their back and better on their side. So with an appliance in positional therapy, then we can treat the apnea easier. And on your back, of course, supine is where gravity takes over and the tongue can fall back, the jaw falls open, and it can compromise your airway. Sleep hygiene is basically good sleep habits. It's not just clean sheets, although I'm sure that helps. But sleep hygiene is white noise, a dark room, stimulating natural melatonin, getting the proper amount of sleep. So if a patient comes back and says, well, this appliance doesn't work because I'm still tired, well, we do go through sleep hygiene habits. And so our goal is that when you are asleep, we want it to be good sleep with an appliance. Pharmacological treatment, really there's no magic pill, there's no magic bullet for sleep apnea. Wouldn't that be nice? However, we do utilize some things in order to clear the nose. Nasal breathing is of utmost importance. also is so important to me, so I can predict and see nasal obstructions. We need to get the patient breathing through their nose. That actually decreases resistance because we have a longer tube that's less prone to collapse. It's going to stimulate parasympathetic activity versus that stress, fight, or flight. It also warms and humidifies and filters the air, which is why God made this. And it also picks up nitric oxide, which is hanging out in our sinuses. So the nitric oxide helps dilate our blood vessels in our lungs and gets better oxygenation of our blood. And then CPAP, we talked about. Problem is, yes, they work. They only work if you wear it. And then, of course, an oral appliance. The surgical options, there is a ton of surgeries available now. Traditionally, in the past, it was that UPPP where they cut out it's uvulo, pharyngeal palatoplasty. So essentially shaving the pharyngeal walls, the soft palate, and the uvula to try to create more room. The problem is most of the constrictions are in the tongue area, and they found that's only about 30% successful. But the patients thought they were cured because they were quieter. And there's not a lot of follow-up on those surgeries. One of the best surgeries, and now there's something called Inspire, one of the best surgeries is maxillomandibular advancement surgery, 90% effective. It does change the way the patient looks, but if we could also get some maxillary expansion, that has been shown to improve sleep apnea. I mean, change the anatomy, right? Those are very effective. I have a patient that went through a SARPE, and it was beautiful because his maxilla was expanded in just 6 weeks' time. And I was working with an orthodontist and an oral surgeon so that we can get enough restorative room. We weren't using that for treatment for sleep apnea, but more because of collapse of his front tooth. So there's a lot of options out there and way good research showing effectiveness. So the way that an oral appliance works is that since the muscles of the tongue and throat attach to this lower jaw, by bringing the jaw forward, posturing the jaw forward, we're going to prevent the collapsing of the tongue. We're going to prevent the collapsing of the hyoid bone. It's going to support the hyoid bone, which is that free floating bone, and the tongue muscles go with it. But in addition, this pterygomandibular raphe that's attached to the mandible tightens. And attached to the pterygomandibular raphe and to the hyoid bone is the constrictor muscles. And those are circular. And so by bringing the lower jaw forward, we're actually opening up the airway volumetrically in all directions. The pterygomandibular raphe is attached to the tensor veli palatini, which is attached to the soft palate aponeurosis. All of that is just a fancy way of saying it tightens the tissue in the soft palate so that there's less vibration and less noise. So it expands our airway, kind of like I said, in all directions. And effectiveness increases over time because once you have an open airway, then the swelling goes down, the muscles tighten up, and there's more room. Again, here is just a graphic to show you how CPAP-centric the U.S. is. And it's because that's what they know. Have you ever noticed medical world's kind of afraid of the mouth? They're afraid of the oral cavity. If it has anything to do with that, they're out. And so there's unfamiliarity with the treatment and which appliances. And what if they get a question that they can't answer? And so it's been my mission to help get the word out there that appliances do work and patients want them. So in dental sleep therapy, no matter where you get the sleep test from, whether it's when you provide the patient or you do a third party that mails the patient the sleep study, or they go to the sleep lab, regardless of where you get that sleep study done, that's the first step. So when I bring a patient in that's had a sleep study, then we go over that. They love me going over it because no one has before. They're like, wow, no one's ever explained it like that. And then again, they just get more ownership and the light bulb goes off. So at a consult, we take our cone beam, I do an exam. Are they a candidate? Now there's certain things that I look at to see if they're going to respond with an appliance. And so it's not just by looking at someone, the sleep study gives us hints, their anatomy gives us hints. So then when we take records, we think, okay, we think it's going to be a good starting position here. There are some other tools that people sell to try to find that starting position. However, it's still a guesstimate at the end of the day. And then we deliver the appliance, and then we have the patient move it forward or backwards based on their symptoms and are they still snoring and how do they feel. And then at about the 1 month mark, sometimes longer if needed, we do a follow-up sleep study with the appliance in place. And then we're like, pray, we hope we got it. So there is one way we can determine that starting position. We can tell if the patient's a responder prior to treatment of a custom oral appliance, because we do have to tell patients this is medicine. There's no money back guarantee. We're pretty sure it's going to work for you. According to the research, it should work for you. But I can't guarantee it. And that's where the simple sleep solution workflow comes into play. It's a purely digital workflow. So there's no impression material, which is cool. But most importantly, we can take a lot of that guesswork out. And we as a dental community hate guesswork, right? And also, we hate chairside time. We want to limit the amount of time patients have to come in. And so if we can give a predictable starting position or in a predictable place, then we don't have to see the patient as much. So we can go from a position of we identify this in our patients, we get it diagnosed, we find out if the appliance would work for them and at what position, and get them there. So again, the way that we do that is with a Matrix Plus. It's by a company called Zephyr that has partnered with Dentsply Sirona to distribute this. It is a wonderful tool to have. So we can predict who to treat and how to treat it. They say about 60% of the population responds to oral appliance. But in all the Matrix Plus studies, and they have validated good research, what they found is about 70% of patients do. So that's good news. But that also means that there's patients who don't respond. And so you make them an appliance, you do all this guesswork, you do a follow-up study, didn't work, you have them advance, you add vertical, you do a follow-up study and it's just still not working. Wouldn't that be nice to know beforehand? So when it comes, there is this is the unit that is worn on the chest, and it comes with a tablet. So the instructions are very, very easy. In fact, the patient cannot move forward until everything's plugged in correctly. And it's all on the cloud so that we get real-time data of did the patient successfully do the sleep study the night before. And what it does, so the way that it works that's different than any other sleep test out there is that these trays here are basically lined with blue mousse material, bite registration material that's by Sirona cells, and is attached to a motor. So the person has specific trays for them with their teeth and attaches to this motor. The motor is less than 3 ounces, so it's very comfortable. Plus, it comes with a pulse ox and a nasal cannula and an effort belt. So this is how we can determine obstructive sleep apnea. How often is it an apnea or a hypopnea? All those things, and for how long were those desaturations? So the first night would be without the trays in place at all. The Zephyr cloud does have a sleep physician on staff, or since it's on the cloud, you can use a local sleep MD and get a diagnosis of obstructive sleep apnea. So of course that would be done without the trays, but it does have nasal cannula, effort belt, all of that, so we can determine the level of sleep apnea. Then the next night would be what's called a theragnostic study. So theragnostic, what we're testing to see is if the therapy would work. So if there's an oxygen desaturation, then the computer, basically the motor moves the mandible forward, back and forth throughout the night at 0.2 to 0.3 millimeter increments. And that's just enough. It's not enough to wake the brain up. And most people can tolerate this study, even with something hanging out, because they're getting better, deeper sleep. And so they kind of sleep through any sort of arousal that might occur. So here I am all hooked up. I did it for 2 nights, and basically it confirms that I can't breathe out of the right side of my nose. And if my jaw drops, and that I'm retrognathic enough that that's what is kind of affecting my snoring. So I didn't snore that night. My husband loved it, and we could kind of find the best position for me. So when the study comes back, there's essentially 2 nights with the motor in place. The first night is the dynamic night, and that is where it's moving all around. You can see here, in fact, there was 375 motor position changes. Then the next night is the static night, and that's where they go to the position they think is best and tweak it from there. So that next night, in this example, there was only 3. And then it tells us if the patient is a responder to an appliance, and then at what position. So that's the beauty of this tool. Then what we can do is take those trays at the position that it found, take the cone beam with that bite, import the files from the scan that we take of their teeth, and we can get an appliance at the exact position that we want. The patient, in the meantime, gets to take these home and sleep with them as a temporary appliance. So we take the cone beam with the appliance in place at the target position. And I will tell you that if you guys don't have a scanner, Prime Scan is the only way to go. I've tried so many others, but I can't tell you how much faster it is, how it cuts out the cheek and the tongue and anything that's not supposed to be there. Also, it scans edentulous areas. If you're a general dentist, we do use chairside milling, and that has completely transformed the way we practice. It's gotten the team excited. My partner's excited about dentistry again, and patients pretty much love it too. But the Prime Scan is a game changer. I use it for edentulous implant cases, and the metal crowns and all of those things are so much easier to scan. It is considered an open system now, so I can use other labs aside from just Sirona Connect, and it's easy to clean. It's all touch screen. So here's kind of the CCAT software where we can do this all digital. You can see up there that we can import the data from the scan into, we just import the SSI file in this case. And it just needs to find some points to correlate. Again, these are full arch scans because we're going to make an appliance on the full arch, and it imports it. And then we do the same thing for the lower. Then when it's imported, we take a scan with that bite in place. And then at the very top of the CCAT, we can just click the shopping cart and it gets sent to Germany, and with nothing to mail except the appliance when it comes back. Now, you don't have to take one beforehand for the OptiSleep. That's the appliance that is made in this digital fashion. It is a milled appliance, but we definitely need the one with the bite in place for the treatment position. And this is the OptiSleep. So it is, you can change these bars out. But again, we don't have to do a lot of changing of the bars if we use the Matrix Plus, because we can find that target protrusion. This material, it is milled, so it's pre-shrunk. It's very strong without the bulk. It's a great appliance. Other appliances that are milled, I think there's a huge advantage to milled, is the Somnomed Avant. It's got a nice flex liner material. So you don't have to make just the OptiSleep because every patient is different. I live in a place where Medicare rule the day. Even with our private insurance, we have to follow Medicare guidelines, and that requires a telescoping hinge. So I can make a milled device that follows Medicare guidelines for my patients, so that's what's better for them. And then this is another milled version without the hinge. So we can utilize other labs as well, but really the digital workflow has just transformed my sleep practice as well. So with the Matrix Plus, we can really cut down on those follow-up appointments and adjustments for patients, and limits the chairside time, which is, to me, is the most important. Now I'm going to have a couple case studies here where Rodney, he's been a friend of mine for a long time, and he finally came in with his tail between his legs, admitting that I think it's time. And that's because he had 2 different panic attacks in the middle of the night because essentially his airway was closing off, and he said, it's time. So he also didn't like the fact that he was getting older. To him, I was admitting he was old. But over the years, he's a triathlete. He has gained some weight. He's finding it hard to get motivated, the choking at night. So those were his chief complaints, and a lot of sore throats and kind of a raspy voice. So we did a diagnostic study utilizing the Metabite Junior and a sleep physician. And what it showed is that he had an AHI of 51.5. And I said, Rodney, you are too severe for me to help with an appliance. But with his lifestyle, with him, he just knew he couldn't tolerate a CPAP. And I said, the only way that I'll make you an appliance is if you pass this test. And so here's the second page of that Metabite Junior. It just shows he pretty much stops. These hash marks show when he stops breathing. It's pretty much all night, tosses and turns, gets up many times a night, out of bed, and he has some pretty severe desaturations. So you can see kind of highlighted there, that's when he's not breathing and how many times he wakes up. But what I did is send him home with a Matrix Plus. I said, you have to prove to me that this is going to work for you. He ended up needing 3 nights to prove it. And the tablet and the cloud tell you how if you need that or not. So he had 384 position changes the first night, and then 5 and 6. Well, we gave this to him on a Thursday. And when he brought it back Monday, he said, when Saturday it was done, it must have been somewhere. Saturday he was done with the test. He started to duct tape those trays together because he had never gotten such good sleep in his life. He had forgotten what it was like to get a good night's sleep. And even with those temporary trays, he got a taste of what it would be like. And what was most surprising is that he actually was a responder, which was the best part. And I could not believe it. I would not have predicted this. I would have sent him to get a CPAP. And the position that it was surprising as well. And so he's been wearing his appliance at this protrusion. We just did a follow-up study on him with the appliance in place, and he could not be happier. In fact, he wrote a check for the full price and got a second one as backup. Then I had another patient. I think they're all around this age. Isn't that funny? And not really overweight. A financial planner saw me at chamber. He goes, it's finally time for me to come in. And so when he did, we discovered that he had an AHI of 43.9. It is in the severe category, but I think I was most concerned about the fact that he had a lot of apneas versus hypopneas, a lot. And he had some pretty severe desaturations. So with this is my little note saying that in order for me to make an appliance for him, he needs to have a Matrix Plus first. And what we discovered is that he wasn't a responder. So how much heartache did we just save? How much frustration? How much money? And I have to tell you, psychologically, it prepared this patient for CPAP. And I said, you know what? I'll always be here for you. Something is better than nothing. And we can find like maybe what was the best position for you. But at this point, CPAP is what is best. And they appreciate that. And a little unwilling still, he went and got a CPAP and wears it. So we really want what is best for our patients. And we want to take a lot of that guesswork out. And this tool certainly helps us. So again, joinsleep101.com is where you can get notes, and you'll get an email from me. So then you have my email address. And Adam, I can't see the question. So, here we go. I got him. It asks what kind of cone beam. I have the Galileus. It has the ASI. To be honest, I don't know all the different ones. It has the full field of view. I do not get joint, and I don't get SAFs, but I'm not an orthodontist. So we have Airway in it. We have the Airway software to volumize it and utilize the ordering. Then it asks what type, if any, of pulse oximeter do you use? You cannot use a pulse ox to diagnose sleep apnea because all it's measuring is pulse and oxygen. It doesn't really capture. I've had so many examples of people that would have been told they were fine if they had gotten a pulse ox. It's almost like a false negative, because I have plenty of patients that on a sleep study show a nadir of 90, never dropped below 90, but yet they had a whole bunch of hypopneas. And so they had moderate to severe sleep apnea. So I don't really use it as a screening tool. Like if you're going to do a pulse ox, you might as well do the sleep study and get a diagnosis. So they're given away pretty commonly in the medical world though, because they're cheap and free and easy to access. But a lot of times when patient says, oh, I got a sleep study and it said I was fine, there's 2 questions you should ask. First, when was it? Should be within 2 years of sleep study. And the second is what kind? Was it one you just wore on your finger? I don't love pulse oxes for screening, but there is some high res pulse oxes that are a little bit more predictable, and I think they measure better there. What numbers are risks for you when you are volumizing? Oh, so, I have a study on that, and I can't remember the numbers right now, to be honest. There's no direct correlation yet. So I will get that to you. I don't know who you are, but Nick. So Nick, make sure you contact me. How do you help someone breathe better with their nose? So that's where the cone beam really helps me. I can identify if it's turbinates, sinusitis, deviated septum. So those surgeries are a little easier to refer for. I have an ENT that I share a parking lot with. Those surgeries are cheaper, but they're also easier to recover from. We also utilize Flonase or allergy medications to help shrink the tissue, but also mute nose cones. They really help dilate. If the patient has collapse, that's a valvular issue, and there's really no good solution for that or surgery for that. So nasal dilators, like Breathe Right Strip works, but that's on the outside. So internal dilators and mute is a great one. Do I screen all sleep apnea patients? So if you become a sleep patient in my practice, I have a lot of patients that come from outside my 4 walls. Every sleep patient does get a cone beam, and we do bill it because we're billing everything to medical anyways. If you want to learn to interpret CBCT, one of my favorite radiologists is Heidi Coltfarber. I still can't say her last name, but Henry Schein and Dentsply Sirona has some webinars with her, and she's wonderful. Stomach sleepers, yeah, obviously it's you can't really use the Matrix Plus with that as easily. But it's very rare that I find stomach sleepers. You probably are, but it's not as common as you would think. So they understand that it might not be a typical night's sleep, and they might sleep on their back more than normal, but that's okay. I charge ask how much do I charge for the Matrix study? I charge a $250 fee. That's essentially the cost of the trays and the program that I had, the membership that I have with Zephyr. I don't bill to medical insurance at all. There's probably a code, but I don't bill to medical. It becomes a hassle for not a whole lot of money. And so a lot of these patients that I'm using the Matrix Plus on are desperate for an answer, so they're more than willing to pay that money. Now, as far as how much can orthodontics do, the jury's still out. Of course, any expansion is going to be helpful. It's going to reduce severity. Is it going to be curative? It depends. That's why it's important to do follow-up. I really cringe when there's people that say, oh yeah, you just expand them and you'll cure them. Like that's a big claim to make. And so it's something that should be monitored for sure. It can certainly give more room to the tongue, but curative, I don't know. And how much so? It depends on the human being. How do you factor with Matrix when patient sleep improves over several nights of wearing an appliance? I don't think I understand the question there. When they're wearing the temporary appliance with the Matrix Plus on, it's because their mandible's protruded and the airway's more open, and they're not getting constantly interrupted so they can get into deep sleep. Okay, so then it says the picture displayed looks like I have the SL. Yes, that does look right with the AI. Then, is the plastic covering teeth hard enough to not change the position of the lower tiers? Yes. So with mill devices, that's another huge advantage, is that it is retainer-like. We don't see shifting of teeth. In fact, the ProSomnus is the lab that makes the ProSomnus IA and pH. They did a study that showed teeth movement is virtually nothing. It's especially even because it is stiffer even than Essex retainers. When we see a bite change, it's usually a small posterior open bite. And that is because of muscle changes or recapturing of the disc. So that's why they think it happens. As far as time, Adam, I know we said we could go over a little bit, but certainly let me know when we have to go.
Yeah, let's do 2 more.
Okay. Then it says, have you heard that sleeping on your left and incline is better for your airway? No, I would say that there's really no difference between left and right. Incline would help prevent the jaw from opening and gravity taking over. The left side, they say, is better because that's where your heart is, and so it improves circulation. There's been like 1 or 2 studies, so I think that's, again, a big claim to make. People are going to sleep on where they're going to sleep is what I've discovered. And usually it's away from their bed partner. And you can tell I sleep away from my bed partner on my right side. And it's usually if they have a bad shoulder or hip, that dictates too. But I live in a place with a lot of retired people. And then laser for the use of soft palate. I think that's adjunctive. If I had a laser, I would buy the attachment for it, but I would not buy a laser specifically for soft palate. So there are some different options out there. What it does is it coagulates, it shrinks the collagen in the soft palate. So it's going to stiffen the soft palate and shrink it. There is some validity you have to do. It's basically a 5 to 10 minute procedure where you wave the laser over it. And then you have 21 days in between. You have to do 3 treatments. It's usually, again, a cash fee. It's going to make your appliance work better. It's not going to cure sleep apnea, but it'll make your appliance work better. So hopefully that answered a lot of your questions. I really want to thank you guys for joining me, and I want to thank Dentsply Sirona for having me. Again, go to joinsleep101.com. And if I didn't get to your question, then certainly... just real quick, with the bite change, we do try to prevent it. A morning repositioner, or chew toy as we call it, doesn't necessarily stop it, but it is something that we try to do to prevent it. If there's a bite change that's significant to the patient, that they have a problem with it, most of the time patients don't even notice it. If it happens, then we always offer CPAP, and the teeth do get back. Very rarely do I have to I haven't yet had to get orthodontic involvement to fix it. So I know that's a huge thing for orthodontists, and certainly we can continue to discover more on that. But the most important thing is getting oxygen to our patients, and we are in a perfect position to do that predictively. So thank you guys so much.
Cool. Thank you, Dr. Elliott, for your presentation, and thank you, everyone, for attending today's webinar. As a reminder, if you elected to receive CE credit, it is required that you complete the survey upon exiting the webinar. As a thank you for attending, everyone will receive a link to view the recording of today's presentation in the coming week via email. On behalf of Henry Schein and Dentsply Sirona, thank you, Dr. Elliott, for an amazing webinar, and thanks again to all of you for attending.
Thanks, Adam.